Um, and they include Melvin Broadnax, who I believe is planning to come here yet today, who is our board chairman. He is a elementary school teacher, a cucumber buyer, a farmer, a pretty large-scale farmer. He is on the advisory board, chairman of the advisory board for the social services, is on the advisory board for the Odin prison. He is very active in the community. He is a town board member in Seabury. Jack Faison is county commissioner and a funeral director, and he is also very involved in the community in a lot of different ways, and was very responsible for this office getting started in this area. Pam Hargrove is an insurance man on the hospital board, is on the community college board, is the president of the, or was the president of the Weldon Business Bureau, has been president, I believe, of the Roanoke Chamber of Commerce, Roanoke Valley Chamber of Commerce. A real supportive, good fellow as well. Bill Edwards is a former county commissioner, was a judge, or I'm sorry, was a judge. He ran for a judge position. He is a manager of a feed and seed operation, has a trucking company, several other business interests. Has been chairman of the social services board as well. Frances McGee is a retired public health nurse, has lived in the area almost all of her life with a very short time outside. Her family dates back to the 1700s in this area, and very, very supportive and fine lady. I'm on the board, and Dr. Berry is on the board. Let's see if that everybody. And Dr. Charles Onakwe, who is a Nigerian OBGYN, who was trained in Scotland, very good hospital there, and then did his residency at Cornell, and is top rated. He's also on the board. That makes up our board. Our board and what we call the leadership team, which is the physician and myself, have a very, very close working relationship. We have not had any real altercations or differences, strong differences of opinion in the 4.5, 5 years that I've been here. The board asks questions about things that they feel are appropriate for them to be involved in. They review our budget and financial statements. They review any significant personnel changes. They have ultimate policy authority over the group and could at any point get rid of any one of us for that matter. But they are a very wise board. They do deal well with the whole issue of personnel. They know which things they should be involved in and which things they should not be involved in. The day-to-day operations are totally up to the leadership. The board really doesn't get involved in that. They do provide a real good outlet for us to the community and a real good inlet from the community. They will bring back concerns, they will bring back support, they will bring back a lot of things that we need to have a group of community folks at something, be it a welcome or a position of whatever, we can get them out. I think Frank was at my house house one time when we had about 75 or 80 people who are decision makers and leaders in the community who came to a cocktail party, which was number one, a little bit of a concern for me in terms of the community and how that would fare. But number two, a party that involved a whole range of people, both black and white, and it went extremely warm, very, very good get together, and not often done, not frequently done. But the board has a close working relationship among themselves. The board selects the board. It is elected, it is not selected by the outside. The board of directors add new directors, and there's a formula for them going off and stuff like that. And Joe and I are very, very involved in the selection of the board members as well. Joe and Melvin and I have worked very closely on adding any new board members to make sure that they understood the type of board we were after and the type of things that we wanted to accomplish. And it's worked out very well. We have one board member who regularly has medical students staying at her house. And when the medical student comes home at 6 or 7 in the evening, she's got a big meal all cooked up for them and has breakfast for them in the morning. And they have a beautiful spot, sort of peninsula in the lake, in Lake Gaston up here. And if we ever have overflow from our trailer that we have for medical students, she'll take them on. And she's also provided a space to have get-togethers of 125, 150 people to welcome a new physician or whatever. And just to have fun as a group of board members and staff people and community people. And that's been really important, the perception of the community of this practice. We can succeed in doing a lot of the things that we want to do because we have a good board and because the board is not afraid to involve the most conservative person in the community in some way, in a welcoming position or whatever. We invite people that may not be very strongly supportive to these things very often, and get real good support, I think, as a result of that. Our practice has been very fortunate in that it's been pretty well accepted in the community overall. Relatively few problems, even though we've done some pretty significantly different things. We are probably one of the first integrated practices in North Carolina. And we have not had any negative feedback, hardly at all, on that basis. It's just been a really good situation, and we've been very, very pleased with it. And something we cannot, underrate. That was an important issue, and one I'm very pleased the community handled the way they did. Dr. Shumter was trying to use in terms of one of his colleagues and the kind of acceptance that he's got from that also has been a real kind of turnaround over time. The medical community, this is very different. You've got a nonprofit corporation. You've got this area that has groups of physicians for the most part. You've got people who are a little bit young and liberal for the likes of many folks. We've got outsiders where all the principles in the practice are from the area. You've got a lot of things that can concern our community and our group of people. So we've been very well accepted. It's not been immediate. It wasn't. There have been problems, but we've been really fortunate in that overall. And from time to time, new things come up, and you just have to deal with each one as they go. Take a second here. Let me hand this out to you. I was talking to you a little bit about marginal cost and average cost and so on. This is an article that I wrote up on that. It's probably not one of the best written articles you'll read in your life, but it's one that I feel is important from the standpoint of treating the indigent patient.
Before the practice happened, that had not occurred with Kevin Angelic. Of course, the Virginia assemblies, as they're called, are board money, foundation money, and others see full access money, registration, 15 years and so forth. And that's spread into these counties.
This is Dr. McCaleb, Jane McCaleb.
She said I was supposed to come talk. So he's going to give me a list and I can choose.
You have a copy of the agenda right with you? I've got mine.
No, is there an agenda? No.
I've got a
See,
little
he doesn't know any more about you than I do.
No. I thought he wasn't with the agenda.
Oh.
I was just a little bit.
He catches me out in houses. Remember, you're supposed to come in and speak to us. What?
You mean Joe? Joe
He says
sent you?
No, Bill says that.
Oh, yeah.
I said, I don't know what I'm supposed to talk about.
You're the only real family practitioner.
Family practitioner. You go ahead and talk. Maybe I'll think of something. What were y'all discussing?
Of course, the almost angelic reception of this first integrated practice, not without huge work, still tremendously successful.
I don't think I raised that question when I interviewed was whether in this sort of setting a black male and a white female was going to go over well, because it's not a usual combination. And Dr. Berry said that he didn't envision any problems, which I thought was just being naive. But surprisingly not. I haven't found that it's been at least something I've been made aware of by the community. I know that there are people who don't come here because Joe's black, and there are people who don't come here because I'm female. But in a way, I think there are people who come to see me because I am female, and as a result, sometimes if I'm not here, they wind up seeing Dr. Berry. They might not see him because he's black, but they find out that he wasn't quite so bad. And when we hospitalize, I don't have my separate hospital practice. He doesn't have to separate. We hospitalize together. So that there are patients of mine who've sworn they would never ever see Dr. Berry because he's black. And I'm sure he's had some that have sworn they'd never ever see me because I was a woman. But when it comes to being in the hospital, they find out they don't really have the choice, and it's too embarrassing to make the point. They don't say anything about it. And I find they accept it pretty well. The only time it ever came up in a real situation that was kind of bad was I had a patient who was supposed to deliver, and I was on vacation, and the obstetrician covering for me was black, Dr. Anaclay. And she told me before she left that she didn't want him to deliver, that her husband didn't want him to deliver her. Nobody ever wants to say it's their feelings. They always say, well, I'm not prejudiced, but my husband is. And I said, well, I would try and arrange with Dr. Chan, who's Oriental. And she said, well, that would be better. And, getting up that scale. But Dr. Chan was going to be out of town, and as a result, I just left. And I explained to her, I had told her I might not be able to get him. And so, unfortunately, she went into labor. And Dr. Anaclay had to deliver. Well, she called the answering service, and they said I was gone, and Dr. Anaclay was covering. And she didn't want to go to the hospital. She was sitting home in labor, and the answering service woman talked to her for about an hour on the phone, trying to persuade her that this was going to be okay. Well, she didn't really have much choice. And I got back Monday morning, and the answering service told me what had happened. I thought, well, boy, I'm really going to get cussed out when I go in there and see that woman Monday. So I just knew she was going to be furious that I'd left her, and she had to be delivered by a black physician. her husband would be upset. And so I walked in and she said, I apologize. She said, he couldn't have been nicer. She said, I know I acted terrible and he was just as nice as he could be and didn't. She said, and I really feel badly that I acted the way I did. So in some ways, there are people that are hardcore you're never going to influence. But I think there are people who have the old traditional values but never tested them. And when they're forced to test them, they start to see it doesn't really make that much difference. If you're sick and you've got a good doctor, it doesn't make much difference. And so people are coming around, and as I said, there's still hardcore people who've never seen this clinic because of that fact. But there are plenty of people who do appreciate that, and I think it does demonstrate to people that black physicians in particular, and women physicians, which is something very unusual in this setting too, can function and serve the community. And as I said, it's never been anything that I've really felt much rejection about. And I don't think Dr. Berry has either. Well, I'm from Missouri, and I went to undergraduate school in Massachusetts, and then I went to Missouri Medical School, and I went to Arizona for residency, so I've been all over. But I liked the Southeast, and I'd already determined, even before I went to medical school, that I wanted to do family practice, and I wanted to practice in a rural area. I hadn't lived in a rural area, but I wanted to. And I was National Health Service Corps. And the Southeast had a big need. There was one area you could always get. You couldn't get the Northwest of California, which is where every National Health Service Corps wanted to go. It was either to New York or California. Southeast had very low requests, so you could get what you wanted. Once you chose that region, you were pretty well assured that you could pick your side. And secondly, North Carolina is the only state, well, at that time, that was really doing much in terms of rural care. It's not very well recognized, I think, by people across the country, but North Carolina has done a lot in terms of committing time and manpower to rural care, supporting rural physicians. And none of other states have been doing that up until this time. Well, this has turned into sort of a model for the rest of the country. So I just sort of said, well, I'm going to pick North Carolina. And seasons, I like having different seasons. And so that was sort of it. And I landed in Raleigh and met Bernie Patterson, the rural health office. And at that point, Joe was here by himself, so Bernie was giving me the old song and dance about, this was just wonderful. There were no problems. It was a great place. And miracles were happening out here in Jackson.
A bill still saying.
Is that right? Well, it sounded like about that high with boots on, And so I said, well, I'll go look at it. But it really, Joe was by himself, and they were really installing the place then. But when I met Joe, he's an internist, and that's something I never would have envisioned myself practicing as an internist, because I thought, they were the last people that understood family practice. Pediatricians are much closer to family practitioners. But Joe's the first internist I really met who had a conception of what community medicine is, who understood the fact that you can't practice in a vacuum. You don't practice on, this person comes in, they've got a cold, you treat it and send them out, and particularly in this community, you don't do that because you can't just say, well, turn your vaporizer on and buy your Dimetapp and fine. They don't have running water, or they don't have enough money to buy the Dimetapp, or, they've got, they got diarrhea, they may not have outside facilities, they may have health needs. And he really understood that more than any other physician I'd ever run into, an internist or pediatrician or family practitioner. And our personalities fit very well. He's a quieter sort of person than I am. I'm sort of assertive. He's really assertive in a quiet way. He usually gets his way. But we fit well together, and so it's sort of, there were a lot of needs he had. He recognized that the big thing they needed was pediatrics and obstetrics in the practice, which they didn't have. And, most internists are just wanting another internist so they can do more cardiology or more nephrology or more this or that. And what he was looking at was what the community really needed, and what the community didn't really need was a nephrologist or a neurologist or that. They needed somebody who could do basic pediatrics, and somebody who could do basic obstetrics, and somebody who could do a little bit of this and a little bit of that. And I think as an internist, he was able to recognize his shortcomings in the fact that he had gotten good training. He was a great internist, but wasn't serving well over 50% of the needs of the community, which had to be very frustrating for me. They didn't do any immunizations, for example, when I came here. The clinic wasn't doing any pediatric immunizations. It wasn't doing any obstetrical care. So I came, he was here by himself for a year, and then I came at that point. And my frustration became then that I had the training to do the basic stuff, but realizing the limitations, particularly at the hospital, of working with obstetricians and pediatricians who didn't have the same philosophical view that you should try and save babies and not just write them off, that I wasn't going to have an impact on that because I wasn't a pediatrician, I wasn't an obstetrician, I was a family practitioner, which they'd never had before. They didn't have family practitioners doing obstetrics until I came. I wasn't a pediatrician, so I wasn't going to get the sick babies referred to me. And I was a woman, which I was the only woman on the staff, and I was new, just brand new out of residency training. So our next critical step was to get Dr. Sumter, did they meet Dr. Sumter? Yeah. Who has the advantage, as he says, of having gray hair and being a male and being board certified in pediatrics and having years of experience. You know, it's hard to question those sorts of qualifications. And so since Ed's been here, we've really been able to make an impact on the pediatrics in the hospital. And that was really an important step, I think, was getting Ed in. I mean, all of them have been important. But that's where we really started to make an impact on our neonatal mortality in the hospital up until then we were having a nice time because they would, you get a 2-pound, 2-ounce baby and then they keep it a week until it died. People just wouldn't bother to transfer because then, you know, they were going to make it, they'd make it. If they weren't going to make it, they weren't going to make it. You know, there's no intervention. Since Ed's been there, those babies get transferred up really quickly now. I saw our neonatal mortality drop. So it's been interesting. We're making progress, but I don't think we've solved the problem yet. We're working on it. If we get tons of money, we will.
They wouldn't take you, they wanted the foundation different.
Are there other issues you wanted to address before I go back?
Other questions?
How do you feel about dealing with interpersonal stuff in the office, dealing with people that you work with, dealing with people who are your peers and people who are different relationships?
Oh, that's an interesting question because we've gone through so many changes. When I came, of course, it was, I don't know exactly what had gone before, of course. There was another physician here and he had left, and it wasn't exactly a friendly party, and I think there had been a lot of staff controversy over that. And when I came, there was a physician's assistant who wasn't working out very well, and we had a nurse practitioner student in training, and the physician assistant was very good. It was just a personality problems that he had, and he wasn't really happy doing what he was doing, and it was quite evident he wasn't happy. And so I think we went through a series of changes. I was also kind of threatened, I think, when I came in because Joe had established very close relationships with certain staff members, and then when I came in, I didn't have to work through all the old-time things. You know, he and I were immediately able to work together very well. And I think that was kind of threatening to some of the staff members that I could come in and assume a new role vis-a-vis him, which had never been with the other partner. And so there were times when people would go and say that I treated them differently than somebody else, and, you know, they'd go crying on their shoulder about it. Things like I invited somebody to dinner at my house and didn't invite the other person, and, you know, it was really. And then we worked through a lot of that. There were a lot of staff changes, for one thing, and then we started doing a thing which I think has been the biggest help, which is once a year we take an entire day and close down both clinics, and we hire a man from Colorado named Tom Isgard. He's a psychologist, and we go to some place like Williamsburg or Raleigh or Chapel Hill, spend the night. Half the group goes out parties, the other half stays and plays cards, and then the next day we just sit down and talk about, you know, what are the issues in practice, what are the problems we're going through. And it doesn't solve everything. You still have a lot of the same personality problems, or, you know, people don't get along. But it makes people at least feel like they're being listened to and that people care whether they're happy or not. And it hurts, you know, when people have been with you a long time decide to quit and go on to another job. But we also realize, for example, our nurse practitioner's leaving. was hired as registered, she was an RN at the hospital, she was hired, sent to training, did her training and precepting here, has worked with us, 3 years since then? About 3 years.
About 3 years. since.
And she's leaving, but it's really a personal growth thing for her. She needs more than this clinic's able to give her in a lot of personal areas. She wants to go on and get a master's and go into administration. And she's a black woman from this area, and in terms of personal sorts of outlets, I think there are a lot of limitations for her. And she needs some different exposure outside of the South. I think she needs to get to the North for a while and see some different things. So I guess it's to answer the question, it's not really easy. It's not, though, I don't find it a level type of thing. In some ways, Joe and I aren't as close as, say, I will be to somebody else, say one of the nurses. Say one of the nurses, for example, is one of my best friends, and I see her outside of work, whereas I don't see Joe outside of work at all. And some of the nurses socialize, and some of the staff. So it's not really a level type of thing. It's more of, I think we work more, and certain people get along well, and there's certain alliances you see in any large group. But I've never found ours splitting along a racial balance. I've never found all the blacks over here and all the whites over here, for example. And I've never found it splitting along, well, here are the PAs, the nurse practitioners, here are the physicians, here are the nurses, here are that. It's just a matter of personalities is how we split along. And we have the same communication problem everybody else does, particularly when you try and run two offices. You know, somebody tends to think they're not being favored, or they don't get what they want. This office get everything they want. And what happens is nobody gets exactly what they want. They always think somebody else is getting exactly what they want. So getting away once a year really helps that, because it kind of, for a while, soothes it down, and then by the time November rolls around, we're already. The first time we did it, nobody wanted to go. The second time, people sort of wanted to go party, but nobody wanted to talk. The third year it rolled around, people were making their lists up about a month ahead. I don't know what I'm going to tell him when he gets here. You know, I know what it's going to be. And so people look forward to it now. I think we really can. I hope we can continue to do it each year, because it's been, I think, one of the best things for showing the staff that you really do care. I guess the biggest problem you have, I find, is people not being assertive. We did an interesting rating sort of thing on who was assertive in the group and who wanted to be instructed. All four of the nurses came out as being so low in assertiveness. And the guy who was running the group said, I just want you all to realize when you don't get your way, it's your own fault, because none of the four of you will tell anybody what you want. You know, that's what I feel constantly. If somebody would come tell me what they wanted and not just bitch over there in the corner, I'd try and help them. But they'll come tell me, oh, this is what we want to do. So we'll get into our monthly meeting. This happened last month, for example. And I brought up what they wanted me to bring up. You know, I was going to tell them. Not a one would support me. Not one! Bill says, well, shall we do it or not? And I said, well, I guess if nobody feels like we need to do it, we won't. So I go back to my office. 2 minutes after the meeting's over, they run in and said, can we do it anyway? I said, not if you won't support me in the group. You know, you guys have got to get in there and say what you want. And that's very difficult. Nurses have a difficult time with doctors and directors, because they've always been taught, don't tell people what you want. You know, you're the handmaiden of the doctor. It's very difficult to train people that they don't have to be that way, because they've been sort of self-selected to be that kind of person. And I find that more frustrating than anything. If people come out and say, God damn, I hate the way you do that, don't treat me that way, I'd quit doing it. But I don't know, sometimes, you know, what I'm doing that makes me mad, or those sorts of things. And I think that's our biggest problem with communication, is people not being willing to say what they want.
Now you have a private life here in Jackson.
It's not, well, it wasn't easy at first, because when up until a year ago, I was on every night except 1 weekend a month. I would take off, and we hired somebody to cover the week for 2 nights. But then we got 2 other family practitioners in Littleton who were very good, and I'm on 1 out of every 30 night. It's like a vacation thing, and we're getting a 4th one in August, so we'll have 1 night a week and 1 weekend a month. And I have to find it very enjoyable. People say, oh, you live in a little town, everybody knows your business. You know, well, you know, I don't do anything that I care about if anybody knows it. If they want to know it, fine, they can tell anybody they want, as long as they will come tell me about it. You know, they can discuss with every single person in town, just don't tell me anything they know about me, you know, because I don't care if they spread all sorts of rumors. I hear weird things will come back every once in a while. I don't care. You know, it doesn't bother me. I'm not the sort of person where I get all uptight if people are saying, you know, I'm doing such and such. And that's just one of the risks of living in a small town. But on the other hand, I find advantages overwhelming. You know, people are really interested in what you're doing if you're going to be gone. If my father gets ill, and they've never even met him, and he lives halfway across the country, if my father gets ill, in the next month, 20 people come up to me in the store and say, how's your father doing? You know, I hear he's ill. How's he been doing? And for a year afterwards, every time I see you, they'll want to know how your father's doing. How's he doing? You know, and in the big city, nobody gives a damn about that sort of stuff. And so if I'm out of town, everybody will know when I get back where I was, what I did. They'll come up, how was the beach? How was the beach? It's fine, you know.
Which way do you go out of town? How many ways?
How many ways can you go out of town?
Yeah, I mean, where do you spread out to?
I usually stay close now. I'm a homebody, so I don't like to. But we go down to the beach in Nags Head or work to Washington, D.C. occasionally. But you can go to, Washington's 4 hours, the beach is 2 hours. Raleigh, Chapel Hills, an hour and a half. You can go to Mountain View, 4 hours. You know, I don't find it I'm tied down. I lived in Boston. I lived in Tucson. I mean, a big city. And you could go to Symphony and do it. I never did any of that stuff when I was in a big city. Yeah, I miss having a good bookstore. We don't have a good bookstore, and I miss having a good record shop. But if I really wanted to, I could drive to Chapel Hill once every couple of months and stock up. When I'm down there, I go to the bookstores and do that. And so it's really a matter of what your interests are. I wouldn't recommend it to everybody. If you're interested in going to the symphony every time. The only thing I'm really frustrated now is I can't see Gandhi. You know, it hasn't come within 60 miles. You know, I keep looking at the newspaper, Gandhi within 60 miles. And I've decided next weekend we're going to Norfolk to see Gandhi. And that's the first time since I've been here. I've really been frustrated. But Burt Reynolds will not star in Gandhi, so I know it won't come to Rome Breakfast. Unless they have a little alien creature or Burt Reynolds, it's not likely to play. Or if the verdict played for 4 days, I'm sure that was as long as it was on. Whereas Burt Reynolds and Hooper will play 6 weeks. So that's a little frustrating at times, but it's really a matter of what you want to make out of it. I think there's a lot to do. I'll tell you why I enjoy rural practice. I think you can go into a large city and you can do the sorts of things I'm doing here and do fine. But the thing here is that the people here are really in need, and it's the one place I think where you can go and in 10 years you can look back and really know that you made a difference. It wasn't that you happened to be on call that night and you made a difference between that baby living and dying. It's the fact that you even were there, and the fact that you cared enough to even bother to send somebody down to Chapel Hill, Greenville. And seeing attitudes change in the medical community, I think, are really important. And it's just starting in this community. And it isn't any one person. It's a series of people who are coming in and are making the changes. But I think that's interesting to see a community go from being 50 years behind the times to suddenly getting into a modern age, and to really see the difference in the quality of care that people are getting. I find very interesting. And I don't think you can find that in a large city, because you're one of so many that you can't really see the impact on a large scale like I think we would be able to see here. I really feel like this county started out when I came here with an infant mortality of 23 per thousand. A neonatal, babies died in the first 3 days, first month really, but 23 per thousand. And I really expect by the end of 10 years that we'll have it down to the average for the state, if not lower. And this part of North Carolina is the worst. Eastern North Carolina is terrible. But I would be frustrated if I thought it was things I couldn't control, but I've seen so many things that were just a matter of somebody carrying. I had, the classic example was a woman I had who she came in on her 5th pregnancy, and she'd had 4 previous babies. 3 of them had died. She had 1 baby that lived because her mother-in-law had taken the baby away from her. And the woman was sitting hallucinating. She was an absolute out-of-the-world schizophrenic who nobody had ever treated. 2 of her babies, it turned out, had died because they were born at home and she'd never taken them out of the amniotic sac. They just drowned in the placenta. 1 baby died of pneumonia at about 3 months of age because she never took her to the doctor. And this woman had no chance. You know, she lived in a house where there was no road. If water rose in the creek, you couldn't get across it. At night, the family was not going to leave. There was no telephone. They had no way to get access to anybody unless somebody walked down the path at night and went across and got somebody to call the rescue squad, and the rescue squad would have to get out there. And so what we did was we contacted ECU where they had a psychiatrist, and they committed her to ECU OB service when she was termed. She delivered the baby there. The baby was put under Child Protective Services. They found a sister who was competent, who was willing to take the baby and the mother. The sister got custody. She lived in New Jersey. She got custody of the baby, but she was willing to take the mother, who was very interested in the baby and wanted the baby and picked out names and clothes and wanted to take care of the baby, but just didn't have enough sense to do it. She took that baby back home with her, and the baby did fine. And that baby, to me, was another baby that would have died if somebody hadn't bothered to do something. But all it took was one baby had managed to live because there was one woman who cared enough to take the baby away from her. But somebody should have intervened long before that. 3 babies should have had to die before that woman got help. And it wasn't because she was cruel or dumb or anything. She had a recognizable disease that nobody cared to treat. And to me, that was really a medical nightmare that somebody refused to recognize that woman needed help. And I think it was really good that baby, she got to keep her baby in some sense, but she doesn't have the responsibility of that baby. And so I think those are the sorts of things that if you care enough, you can make a difference. And it didn't take, I didn't do anything except refer to ECU and be sure that social service followed up on her, talked with ECU about her. They did all the paperwork. They found the sister. They did all the work. But I don't think if we'd done that, that baby would be alive. I think it would have been another. She had a sister who had 2 babies that died the same way. They just didn't take them out of the bucket. And it's really pathetic. So now that you're all ready for rural health, come on, practice. I've got to go see some patients. All righty. Nice talking to you.
Thank you.
Bye-bye.
This is the one piece of paper that I want back from you all. I think you'll find it to be interesting, and we can go over it maybe a little bit and talk about it. This is our budget for this year, and one that I hope we get very close to, because if we don't, we're going to have a hard time. One extra there, I better take once I know what I'm talking about. Let me just move along to this now before Dr. Berry comes in. Actually, I've kind of divided things into 6 areas, and we've really kind of addressed 3 of them quite a bit, but if you want to go back and talk anything about specifics, I'll be happy to. 6 areas I've got are community, healthcare issues, community relations, then budget and financial, staff, personnel, and organization, and building programs. We've really talked a lot about the first 3 and a little bit about the one on staff, personnel, and organization. Let me move to the budget and financial issues and talk a little bit about that. None of what we're trying to do here can happen unless the money is available to do it. And it's not a matter, I feel fairly strongly, you can tell from my background I've been involved enough in community action kinds of things that I'm not negative to federal involvement in those kinds of issues. At the same time, I think that in this setting, in many settings it may not be right, but in this setting, in this time, with this group of people, it is important that we not have too much federal control of what we're trying to do. The private nonprofit type situation fits us very, very well. We have the option of running our own practice clinically. And it's really worked out very well from our standpoint. And so, unless the money's there, you're not going to be able to operate. I'm not going to spend time now on this since Dr. Berry's here. We can finish up with that.
Go ahead, Bill.
No, I'm just talking a little bit about financial. I'd rather have have you talk a little bit now.
Okay, I'm not too sure what
Okay, essentially, the kinds of things we've been talking about is just the community, in terms of the needs and the makeup of the community. Generally, it's been a question and answer kind of thing. Healthcare issues in the community, just in a very, very specific kind of way in many ways. Both Jane and Ed have talked a lot about that. And just community relations in our board, and we've talked a little bit about staff and how we deal with communications issues and things like that. That's kind of the general areas that, and then of course anything you want to talk about in the budget, financial, and building program if you want.
I'd feel comfortable just fielding any questions, if there are any left, after I'm sure you and Jane. One thing I want to mention that's getting into the area of budget, that because it's very difficult to place a monetary value on what an individual is worth, the cost of medical care, of course, is rising at a tremendous rate, but some limit has to be placed on the cost, the dollar amount of expenditure for health care. And physicians, medical care centers have to identify what those limits are, have to be a part of identifying what those limits are for how much we're going to expend for health care. And we have to make sure that we're getting the most for our patients for the dollars that we're spending. And that's asking that we as physicians, as healthcare centers, be more efficient in the way we deliver care as part of providing an excellent form of health care. So physicians are very much into what's going on with the budget and how we're spending the money, and making sure that the patients are getting the most for the money that they're spending. Now, if there are some other questions, that was really the only kind of general comment I'd like to make. If there's some other questions that were raised, I might be able to be glad to.
What kind of decisions do you make for partners as a physician?
Well, I think one thing that can be done is examine problems in the way that you're handling them, and try to handle problems in a consistent manner through protocols. And then you follow the protocols after a period of time and see what your outcomes are. If you're doing A, B, C, and D to get outcome G, then what happens if we eliminate one of those steps? Are we still getting outcome G, and with a reduction in cost? So those are types of things more in terms of research that you can do, but that's being done across country, so we can look into the literature and see what types of things, like x-rays. If somebody comes in with an injury of lower extremities, there are now protocols that say what type of individuals who've had injuries in lower extremities warrant x-rays, which types do not. Same thing for head injuries. Which, if someone's in an automobile accident and has a head injury, what are the types of things that we look at and say, yeah, well, the x-ray will tell us something that will aid in the process of patient care, health care. So that's one area that physicians are involved in. I think we're all just, at some level, very conscious of the amount of tests that we order, the amount of referrals that we order, just by being sensitive to this and sensitive to the morbidity from the tests themselves. The tests are not benign; they cause problems, and that too increases the cost of health care. Medicines cause a lot of problems. When the most common cause of a health problem in terms of admission to the hospital are doctor cost problems related to medications. Extremely common. So, we have to be sensitive to these issues.
Dr. Sumter was talking about the pulmonary illness that he saw, and he said he'd never seen any higher. Do you find the same thing? Do you have any ideas
Yes.
as to why that is?
Well, and before coming to this area, I think I tried to get a picture of the health care needs, and this information is already published. And what came out is that This area has a very high incidence in cardiovascular disease compared to the whole state, high incidence in pulmonary disease and cancers, and then of course the perinatal mortality issues. So not only in children but in adults as well, there is this problem with the respiratory illnesses. Now, no, I don't know why, but this is an area that we are trying to explore and trying to get some ideas. We do have some industries in the area, J.P. Stevens, textiles. We also have the abundant use of insecticides. I think they may be playing a role in the farming, and the dust from the farming, things of that nature.
Are you doing epidemiology on it?
Not yet, but we will be.
Uh-huh.
One question from, sort of a general question, just about how this practice is doing, the community responsive practice, and how you feel you're addressing the needs, and how do you get feedback from the practice as to where you are now in the community?
I think the main way is actually just being a part of the community in all aspects, in the schools, the religion, the social clubs, just being a real integral part of the community. And you'll get your feedback. But it also helps on a more official level to have a board made up of individuals who are in the community, who have feelers, who've been in the community for a number of years, and feel free to tell you when you're not doing something right or when you are doing something right. So that, I think those are the most important ways. But being a community responsive practice is going to mean different things for different communities. And for example, in our community, our schools aren't accredited. So for our practice to be a community responsive practice, we have to focus issues related to education. That may not be the case in other areas, so it's going to mean different things to different communities.
What are your involvements in the communities, more specifically?
In our practice,
No, you within the community here.
well, I'm on the board of my trustee board of my church. Involved in whenever any of the community groups want me to speak on certain health issues. I'm on the board of education. Let's see. I guess those are the main things that are in the community. When issues come up in terms of water, bond, referendum, or in terms of sewage, I go to those meetings in the town hall and speak toward those types of issues. So does this bill. So do all of us in the practice.
Mental health board.
Mental health board, yeah.
Has been appointed EMS board.
Yeah. Some of the things.
I can probably, well, just the medical societies as well, for both the Halifax, Northampton, and Northampton has been that kind of thing.
How much have you had an obstacle with you being black in an area that's known as being biracial?
I don't know, because I don't work in that way. I don't look at obstacles. I look at goals. And so I'm almost oblivious to obstacles. So I am not aware of there being obstacles.
So, I mean, you haven't had crosses burning on your lawn or anything like that?
Not to my knowledge. I think I would recognize the crosses burning on the lawn. Not to, but no, I have not had that.
I was just asking because I remember I was in Hubbard,
Right.
and there was the country club that no blacks were allowed to be a part of. And I was just wondering if that kind
There are
of
the
thing.
country clubs here that blacks are not allowed at, and there are other clubs, I'm sure, that blacks are not
How do
allowed.
you deal with that yourself, being, you know?
In terms of it bothering me personally, it doesn't. because I don't really want,
Right.
not really interested in playing golf.
Right.
But in terms of what it means, and in terms of the mentality of the community, and in terms of how we can progress, that does bother me. And my approach is to try to work through education. And you can't hit people across the head with this. You've got to work in very subtle ways. Just our practice is a model in terms of race relations and how we're able to work together, and trying to instill these same types of models in other institutions in the community. It's going to be a slow process. It took, it's really embedded in the community, in our society, not just in Northampton County. So it has to be in very subtle ways that this is done. But it is something that I'm concerned about, and I'm addressing. Excuse me, I'll be right back.
I think we should flash back, how important Joe was as the first.
Yeah.
First
One of the
idea
comments
that
that I
I
made to
place.
people who were riding with me, that I haven't commented to here, is that, we are a model, as he says. We are the first, certainly rural practice, integrated rural practice, and I believe the first integrated, we're the first integrated practice, or one of the first in the state. It's been surprising at the acceptance of the community, as we talked about. There are some very basic kinds of challenges that you come up against that Joe was talking about, that what that represents bothers you, and you don't necessarily hit people over the head with it, but you do try to progress to a point where that is less of a point. My biggest accomplishment, I feel, in the past year, on a community basis, has been putting together an integrated scout troop, Cub Scout troop. Now, as I told the people, I've been president of the All-White Men's Club in Woodland. I work with them now, and I will, and as long as I'm in the community. But I kind of drew the line when it came to scouting. I felt like there were certain moral points that you were supposed to be teaching at that point, and I really didn't care to carry on things that should be passed. And as Melvin Broadneck told me one time, he said, there's an awful lot of people sitting back there just waiting to raise their hand to say but they don't want to stand out in front. And once you do something, and you've got to be careful, you've got to select it. But once you do something, you do make some progress. And it's surprising very often that the resistance isn't there that you expected. That once the issue is addressed in a proper time, in a proper framework, that the resistance kind of disappears. Now, there will be folks who don't want it to happen. There will be folks who will never be, for example, a part of our practice, and we know that. And that's their problem, And it's a little bit our problem. We don't want anybody not using our practice, but we're not going to change who we are in order to do that. But yet, it's amazing how many things can happen. One discussion I got into with Melvin Broadneck, our board chairman, was about the pool. Again, it's an all-white pool in the town, and it will be some years, I'm sure, before black joins the pool. And we really had a problem when we first came about, are we going to let our kids become members of that pool and be one of the exclusive 40? Our kids very much enjoy swimming. And what Melvin Broadneck told me is, he said, we need folks who, when the vote comes up, will vote right. And if you're not in there, you're not going to do anything either way. And so we went ahead and joined it, and I have no illusion that that pool is going to be integrated immediately. At the same time, I know that today, if that issue came up to the board of directors of the pool, there would be several votes to go ahead and increase the pool. Whether it would make it or not, and whether 35 of the 40 families who own stock would pull out their stock or not, I don't know. But I do know that there's several people who would vote what I think is the right number.
And whether blacks will still want to,
And whether they even want to
Participate.
participate, that's another
Yeah.
issue. But at any rate, I think it's something that I've learned a lot about living here. Almost my total experience with dealing with the racial issue prior to coming here was on an international basis, and it's a completely different issue at that point.
What have been the changes, Joe, that you observed inside the hospital from arriving here as, interns in the hospital? Any progressions, at what points in the direction of using you beyond the use you made of yourself with many people?
I think two things were happening at once here. Number one, I was a National Health Corps physician, and I think the other physicians were a little bit hesitant to make referrals because they thought I'd sort of be in and out, and then they'd lose some type of contact with the physicians that are already there. So I think it was understandable that they wouldn't want to use me as an internist, even though at that point I was the only board-certified internist in the hospital. After a couple of years, I stopped losing an interest in really being a consultant for others, even though there were some cases in which, there are a couple of physicians who do ask me to consult. But I'm seeing myself in a different role as more as being a primary care physician and working as more of a consultant in our group, just as Dr. McCaleb is a consultant for me for family practice issues, and Dr. Sumter is a consultant for me for pediatric issues. I can be a consultant for them for some adult issues, adult medicine issues. And I'm feeling better working within the practice than being a consultant for others. And I think in terms of my own development and the types of things that I'm studying to keep up in, I'm not keeping up in those areas to be that type of consultant. I'm getting more into the primary care by design.
Has the hospital changed with new arrivals as to who's qualified?
Yes, there have been more physicians now who are board certified, and I
So
think
there's
the quality.
an opportunity for them to now be board certified.
Right. I think the quality of the physicians that are coming to the area now is very good. Not saying that you have to have board certification and have good quality, because there are some good, and I'm not doing the physicians at all, there's some good physicians there who do not have board certification. But just in terms of the community's perception, because people are becoming more aware of the issues of who's qualified and who's not, and they're looking to that. And but in terms of that question, there are more physicians becoming certified.
Do you worry about being in a little area of being isolated and losing some of the mainstream?
Exactly, that's very good. That was really, I think, my biggest fear about coming to a rural community is that I would be isolated from academic medicine. But the AHEC program, and I looked at this, the AHEC program in North Carolina is probably one of the best in the state, well known. Other areas I was interested in included Alabama and some other southern states, and they just have a very poor AHEC program. But it was the AHEC program that made me feel I would not be isolated. We have medical students rotating through the practice, which they're very stimulating. They keep us up. AHEC's provided us with a lot of books, the books that we want. We have tapes that we can rotate, and then we have availability of specialists from Chapel Hill and Duke who come and give presentations once a month to the hospital. I don't feel isolated. I think it's there if I want to take advantage of it.
Another question, just, someone will come upon and see, how do you, are you able to get a feel of your affecting change in the answer, for example, population? How do you get that? How do you have to-
You can't get it, but you've got to really study that. And we haven't, as a practice, we've made promises, and we know that this is an area we're interested in, and we're going to do it. But we just haven't, because there are other priorities that have come up. But we still have the data. We've got the database, and so when we're ready, we can just plug in those, plug in the patients and the protocols and the outcomes.
What do you think will allow you to do that before? I mean, once again, giving you more time yourself to go forward.
Well, we were still in the building stage. I see ourselves now as not doing so much building, and now we can kind of sit back and kind of look at where we are and where we want to go. So now is really the time. I don't see much really holding us back. In fact, there's been one group, Dr. Cutchin's group, who has done already a hypertensive study for our area, and he's coming back to do a second sort of follow-up that has to do with outcome. And that we can use that as a basis, but also in other problems too, such as diabetes. We've done it on a short-term thing. I've had students who looked at outcome studies for diabetics that we've had. Not doing a good job with the diabetics, but we have done it on a very small scale, urinary tract infections.
Do you ever run into the issue in a really rural area like this where there are like folk medicine used or people using some of those kind of strange or esoteric practices to deal with things? How do you deal with that?
Right. You work along with it. I think there's some legitimacy to folk medicine, because what we're doing is also folk medicine, and so we work along with it. And if there appears to be something that may be harmful that we're uncomfortable with, we'll let the patient know that we're uncomfortable with it. Turpentine is one thing that sort of comes to mind. There's a lot of use of putting turpentine on the skin and drinking a little bit of it, and putting it in different orifices of the body that we're a little bit scared of. And we kind of make that known, but it's a good cure for worms. It'll clear your worms. And this started as a folk medicine. There are other things like that. So it's a matter of really working with it. In terms of the roots, I've only seen patients with problems with the roots that wind up having mental problems. That's not a fair thing. I'm skewing it now because there are a lot of people who are of various educational background who believe in roots and do not have mental illness who believe in roots. But I'm saying the population that I've seen, they tend to be skewed to those who have some mental illness. So I wind up focusing on that, but also trying to give them a better picture of what the anatomy and physiology is of the body, but also working along, if necessary, with the root doctor, recommending that they go back for additional consultation. I think that's sometimes appropriate. It's a matter of working with, I guess is really what I'm trying to say, rather than against and just downing it because I'm not aware of what the outcome is.
Do you know the root doctor?
He was a patient of ours, as a matter of fact. He died. There are some others in the area that I have not met, but I know of. All right.
Thank you, Jeff.
Okay.
This budget is almost balanced. Not quite. It's been about $25,000. One thing you'll find is that while I say we're 90% self-sufficient, that 10% can give you heartburn. And fortunately, I think we'll have the supplemental grant to help us out a bit in this whole development process. And, but we, the way this is divided out is that on the first sheet there, the revenues are the projections for each of the providers for office charges only. That does not include lab charges. It is only what they would charge for office visits only. Generally, those figures are pretty close to accurate on those. We'll probably do that. One of the problems that you have is that you can set your fees, but you still have to leave a subjective opinion on the part of the provider to say, well, it's a 90040 or it's a 90050 or a 90, and you want to leave that because, to me, the physician has to have a little latitude in terms of what they're going to charge per patient. A lot of times they may feel, gee, I should have seen this patient the last time they came in, and the mid-level saw him. I don't want to double charge them for it. So we'll charge a briefer visit this time and it'll balance out or something like that. No, we don't. We charge the same rate for each of them. In fact, right now, we've got one of our physicians has a lower average office charge than our mid-level. Now that can be a problem. At the same time, it is possible that what's happening is he's doing more of the follow-up visits for patients, and then some long visits. So it's not immediately obvious. But my approach on the whole issue of charges and so on is that, okay, this is our practice. I can't tell you what you should charge for something. I can tell you what our fee charges are, so you have something to go by. I can't tell you totally. Here's your average charge. Take it into consideration, and this is what we need to live on, and you got to come up with it yourself. Our average charge has continually gone up to a point, or from a point where it was very low relative to what it should be, to a more reasonable point now. Because of that, the physicians are interested in maintaining the practice as well, and as long as they have the information from which to make a good decision, generally they'll do so. Now, once in a while I just can kind of keep it up front periodically. I don't try to set charge.
This indicates a lower number of visits than mid-level.
Yes. Mid-levels are scheduled for 2 visits now. The physicians are scheduled for 5 visits now. Then you'll see in terms of other revenue centers, the laboratory, and then the other list, the backup of which is on the second page. Hospital visits, as you can see, are a major portion of it. Interestingly enough, our hospital, we have always under-budgeted on the amount of revenue that we would get from hospital. We've always gone over on the amount of revenue from hospital. Part of that is, and we probably have a little higher average of hospital visits compared to office visits than some of the other world practices. In part because we are the only practice in Northampton County that hospitalizes. All of the other physicians do not do hospital rounds and do not hospitalize patients. They refer them to someone else. So we tend to get probably
You
more.
call that little?
No, I'm talking about Dr. Stanley and Dr. Fleetwood here in Northampton.
Really? Even at private clinic?
Yeah.
What age of?
50s and 60s. As one of the physicians said to me, I decided early on that I could either have a hospital practice or a family, and I chose a family. Of course, it's today, if you're going to have any new positions coming on your staff or recently trained board certified pipe, you can't have a pipe that doesn't have oxygen. It just, it
And
will
all
not
the OB
satisfy.
charges, how much?
The package is $750 for prenatal.
No, you count the entire package, you're breaking it apart and putting it on
That's the entire package.
you charge it all in this.
It's everything but their hospital bill, but the hospital bill's not full.
So you
But it does include.
Gail
visits of
Masson
ours.
is doing 3+ deliveries a month.
Yeah, generally Jane has limited to not more than 5 a month. Hospital consults and emergency room. There is a emergency room group that sees all the emergency physicians, or all the emergency patients, but our physicians are still often called in, either on their patients or on pediatric patients. Dr. Sumter is always called in for a lot of the pediatric, always. He is called in frequently for pediatric patients, be they his or others. So that total for the operating revenue is $503,400. We're projecting about an 89% collection rate. We may or may not make that. Obviously, 1% is important. Every percentage point makes a $5,000 difference to us. We know we can make an 85%. We started being a little bit more cautious on our collection and stuff like that. We hope we can make up an 89%. We get some of the contract things that we do. We get money from mental health for seeing patients every Wednesday afternoon at the mental health center. We get money from the health department on an hourly basis for seeing patients. The same thing with mental health. It's on the basis of an hour. 14 patients at the health department and maternity clinics. The Medicaid and Medicare contractual adjustment is the difference between our normal charge and what we receive from Medicaid and Medicare under the Rural Health Clinics Act. We're under a little bit different reimbursement system on Medicaid and Medicare than most of your private physicians. We're a certified rural health clinic, so they pay us a set rate per visit, no matter what happens in that visit. So if we do a delivery, we get $24.30, and if we see a patient in the office, we get $24.30. And to this point, our fees have not been high enough compared to what they should be, but we've had to raise them gradually. We're in a community where it's very frequent that someone walks into the doctor and comes out with him saying, "Oh, it's $5." There are none of those physicians left in this immediate area now. But they were getting their income, not so much from their practice anymore, as from the land they own, from the farms they own, and the other activities. They also did not have office facilities that were up to date, equipment that was up to date, buildings that were up to date installments.
It's well below normal practice.
We've made a significant change in our fees last January because we had to. We had no choice. And I got a private consultant in to tell me, okay, what is everybody else in the state doing? What's the highest? Before that, I was looking at practices that were somewhat similar in terms of location and everything like that. And I was getting a little bit of false figures on the hospital. But I knew there was a problem in terms of hospital because we see a lot of folks in the hospital, and yet our average charge was below what the average is in the Medical Group Management Association and General Statistics, which you can't, we're not shooting for that. But we were below that. We were below even what was the average in the AMA in terms of our average charge. And I knew that there had to be something. Our hospital, or our office charge was right, and so on. And what I found was that where we were charging $45 for the first day, and that time I think it was $15 for every day thereafter. The sort of highest was $80 for the first day, $40 for the second day, and $25 or $28 for every day thereafter. We kind of went in the middle a little bit. We went with about a $60 for an established patient, $50 first day, $35 second day, and $3 for every day thereafter. And that's made a significant difference already in our revenue. And that's all third party for the most part, or a large portion of it is third party. So while we don't want to raise the cost of medical care, at the same time we've got to support our office, and we've got to, we want a reasonable charge. And as a nonprofit corporation, you are required to charge fees that are equal to your area, because they don't want to compete unfairly with for-profit purchases. Now, how much they enforce that, I don't know, but that is the law, and that was one of the questions they asked me for our IRS certification.
Yeah, could you tell me more about what you group does with mental health? What you group is
Well, Dr. Berry will actually counsel patients. He'll actually see patients, and but they could not have the satellite here in Jackson unless they had. There is no psychiatrist with the mental health here on a 100% basis. They just come in to the office in Union on a every second or third day basis. I don't know exactly what it is. But Dr. Berry has to take care of the medications and stuff for the people who are seeing it. Primarily, although he does do some counseling. And he does some counseling in the office here as well. He would like, I think, often to do more of that. Has done some, I think, very successfully for a lot of people. With the mental health, no, we don't, not mental health, perhaps other than patients there that we might see in the hospital or something like that. Or patients that are our patients as well. In terms of expenses, personnel expenses are just for salaries $298,000. For fringe benefits are another $63,000. For the total personnel expense of $361,000. If you'll notice, that is about between 60 and 70%. Not
Bill, how many
7%.
of the MDs are called out? I mean, you don't have to pay anything if you're on a law basis for the,
You do have to pay.
what do you pay now?
You pay 20. Let's see. You pay
This is for the
20%
NHSC.
of the percentage of revenue that the NHSC physician generates.
It's the lowest part, it's a low charge rate. It's what they generate, is that right?
So let's say that if you take this, say, patient revenue of what we end up with $448,000, you take and figure just very roughly 448. Say we have 4 providers.
You have one NHSC.
We have one HSC, but we have 4. We have 2 physicians, 2 mid-levels, and the NHSC. So that makes
2
4.
mid-levels or both NHSC?
No.
You're adding it up to 4 equivalents, right?
It's 4 full-time equivalents. So of that 448,000, it is assumed then that the National Health Service Corps person makes 112,000 of it. Okay, they start out by taking 20% of that 112,000, so that's 22,400. And then,
That's how much you have to pay them.
that's what we have to pay the court. And then they'll take 80% of another calculation. But at any rate, it now is getting to the point where
Is it costing you like the full course salary almost? Whatever that is, not
it's getting to the
37,000
point
something like that.
where if we can't get waivers on some of them, we might just as well pay the
But
salary.
have you been getting waivers?
Yeah, to this point we have, up until this last year. Now, this last year, they no longer.
So in this budget, you're counting the
Can
payment.
you explain the mechanics of that job? You mentioned
With National Health Service Corps. What happens is that someone who's gone through medical school and has received a National Health Service Corps scholarship to pay their way through medical school has an obligation as a Corps physician for 2 years to the Corps generally. The Corps will then pay the salary of that person during the 2 years they're serving in a medically underserved area. In return, in a setting like ours, they can't even go private practice option now, they call it. But in that case, they will not pay the salary. They can choose to go into a private practice, and the private practice pays, but they still have some obligations as a core person. But in our setting, they come with us, they pay the entire salary. Then at every 6 months, we have to submit what is called a BCRR report, Bureau of Common Reporting Requirements, to them, which lays out what we made, or what we billed, and what our costs were. They don't consider the costs anymore at all in terms of calculating what you pay. We could be an operation that was billing $1 million and have costs of $2 million. And the Corps would bill us the same as an operation that has $1 million in billing and $500,000 in costs. They don't consider the cost issue at all. They only look at what the revenues are. They take a percentage of those revenues based on what they see should be what the Corps person brings in. Fallacy a little bit in their calculations. Okay, Dr. Berry has been here now since 1976, 7 years. Dr. Dice will come in August. We will be billed for 20% based on the number of providers and so on of our revenue for Dr. Dice's time. Well, he's not going to generate 20% of the revenue of his practice in that first year. And particularly not in the first 6 months. He'll be lucky if he generates 5%.
The only advantage to you then is that you're carrying a senior person like Joe Berry who's able to get more from the Corps than what he's costing.
Joe Berry is not on Corps.
Oh, if it's not
Jane
senior,
McCaleb is the only person on
and
Corps.
she's not getting that much above what you're bearing. I mean, at
Not
some
that
point,
much, no.
at some point it'll pay to break out of it. So,
Yeah, you're right.
then go private, and they go to,
Yeah.
will they let you?
Oh, yeah.
Okay.
We're what is called a freestanding court site. That means that we're sort of independent, and we just have court people coming through. And it makes a lot of difference in terms of the pressures they put on us. If you have grant funds in your court site, you have an incredible number of restrictions and reporting requirements. And they've really, in many ways, made those practices non-viable as self-supporting practices. What's happened, for example, and I'm not sure what the situation is today, but a year ago, many of the practices were required to provide for sliding fee scale medications. So if they did not have a pharmacy in their practice, they would have to make an arrangement, a contract with the local drugstore that the patient could come in, pay 20% of the charge. The practice would have to pay the other 80%. They had to provide outreach services. They had to provide transportation services. They had to provide other kinds of services, all of which are really neat, really nice things. But when all of the stuff about cutting out RHI funding, Rural Health Initiative funding, and CHC, Community Health Center funding, came out, what ended up happening is these folks were not able to survive as practices at all if they did that. And so consequently, folks that were serving a lot of people, doing exactly what they had been told to do, were no longer viable. There's a practice in South Carolina that I've seen stuff on their average charge per patient visit that they get funded for, not their average charge per fund, their average funding per patient visit is $50. In addition to that, they get another $15 in patient fees. So their average cost is somewhere around $65 per patient visit. Our average cost is about $35. Now, one could say, and would be correct, that we're not serving all of the needs that those people are serving. But at the same time, we are serving a lot of the needs that those people are serving to a great degree, and certainly in terms of the medical needs, we're probably supporting more of them. In the case of this one, they have trouble getting hospital privileges, so their physicians still have to refer the patients to another physician for hospitalization, so they don't get continuity of care, and so on. And
Pretty good design for them. You know, if they're going to pay more for bankrupt.
yeah, that's all they have to do.
That may be the only
Yeah.
purpose that stopped them to design the whole thing for it, to get bankrupt.
All they have to, well, another example of the issue we were talking about in terms of you have to be able to attract the wealthier people of the area as well, is that in the particular city where the practice that I'm talking about exists, they went to a situation of the medical university has said they will not see any indigent patients. Unless they have Medicaid, Medicare, or can pay the bill, they will not see it.
The university.
The university. The county says, we would like to set up a clinic to see the patients who can't afford to be seen. But we can't support that clinic if you're going to see all the paying patients and only give us the non-paying patients. We're willing to subsidize, but we're not willing to pay the entire cost. The federally funded CHC in the city is saying we can see an additional 17,000 patients, but you'll have to pay us $50 per visit to see them. So, it's just, you've got more medical facilities in that city than you need, and because someone has decided that they are not going to see indigent patients anymore, the indigent patient is going to cost a whole lot more to be seen. And it really gets into a real problem. And if we had to support our office totally from indigent and Medicaid patients, we would have to charge to have this office and the type of people we're using have the same quality and everything. We would have to have $35 per patient visit. There's no way other we could do that. But Medicaid pays us $24. How have we been able to survive it? We've been able to get grants from private foundations. We've been able to have other patients who have medical insurance who are coming in. We've been able to see more and more patients so that our average cost can go down a little bit and stuff like that. But if we were only seeing indigent patients, we would have to charge $35 for everyone. From the indigent, we wouldn't. We'd close, so we'd have the indigent patients who would be seen. because the federal government isn't going to pay for it all. Because they're saying Medicaid is too high already. And those are all the certain ones. The county certainly can't handle it all. The state is already struggling and trying to, they're making us finance their interest costs already. So you get in, nobody's going to pick it up. But as we stand right now, if we can continue getting Medicaid and Medicare with a reasonable regularity, and we can get $25,000 a year in other subsidies of any kind, we can see all the indication. We'll see anybody who walks in our door.
What's the condition of those kinds of subsidies or those sources of drawing up?
The condition is that you have to be developing. You have to be going someplace. It's private foundation money, and private foundations don't want to get into supporting something ad infinitum. So you have to be doing something. You have to be making some other progress.
How available are those kinds of
Difficult, but fortunately we've been able to develop many of them, and it's worked out very well. We could survive without it, but we would have to make some decisions that we haven't had to make yet in terms of the staffing way. And we're not overstaffed at all. I pulled any one of the people that we have on staff out for a week, you will see a significant change in the productivity. We would have a real problem. Something would not be getting done.
How do your providers work? Are your doctors scheduled in the clinic 4 days a week? What's their total schedule and all?
They're scheduled, depending on whether they're on hospital
Mornings and
call.
afternoons and total?
What happens is that each of the physicians has one afternoon a week off. We are open on Saturday mornings. If they are seeing hospital patients, they are scheduled from 10 to 4. If they're not seeing hospital patients, they're scheduled from 9 to 6. If they're, they also have one half day, each of them have a half day a week that they're either doing health department or mental health or something like that. That's essentially what it ends up being is.
Less work and income.
Oh, yeah, right.
Right.
All comes
Their
through the
life
practice.
style, is it?
Right.
Are you saying it's 4.5 days? Not quite. It's something more.
Well, what ends up happening is they're actually working usually 5.5 days average, probably 6 days a week. 1/2 day they are off. There's somebody else covering for them. They are off completely. 1 weekend out of 3, they are off completely. The rest of the time, they may be on a lead call, they may be on a backup call, they may be in the office.
How many hours a week?
Well, in terms of the overall thing, it's really hard to say, but I would say probably somewhere in the neighborhood of 50 to 60 an hour. And that's just, and then see, that doesn't take into account the issues of community. That doesn't take into account the issues of community meetings. Dr. Berry said, for example, he's on school board. He has a meeting at least 2 or 3.
Add another 20.
Really, I mean, the meetings go, with the school board, they go from 7:30 at night.
The lifestyle of the doctors, one thing I want to also get just the time in the office.
Okay, well,
From the
let's just,
hospital, 'cause
okay. Generally,
with more
that's about-
doctors, you can get a
right.
different rotation,
Right.
like James now along with 2 other doctors,
No. Generally, what we're talking about is 25 to 28 hours.
in the office.
In the
That's
office.
what. To get that.
Yes, they take first call for night call for office-based patients. They can't take call for any hospital patients, but they take sort of the screening call on all office patients. And they may may see them or they may refer them to the doctor. There's always a physician on backup call with them so that they can call the physician if necessary. And that's been one of the great benefits of the mid-levels, is if somebody needs to have stitches, very often they can come in and do the stitches. If somebody needs to be seen for cold or sniffles or whatever, they can come in and do that. They're just not sure. You know, the patient calls and says, I've got chest pain, but, you know, I've had it for 3 days. You know, sometimes they'll come in and see them or whatever, and just get a feeling for whether the doctor has to see it, and whether they need to go beyond that. We've got an answering service, which has worked out very, very well. One of our staff people plus another person who handled the answering service, every hour that the office isn't open, there's a person at the other end of the telephone who people can dial either of our phone numbers in either of the offices, and it rings in to her home. She answers the phone. She gives no, you know, she doesn't screen for medical issues at all. She simply says, you know, is this an appointment? Is it a lab test, or is it a problem? If they say it's a problem, she calls the mid-level, gives them the phone number, and they call the person back.
Is that person paid for the time?
Yes. It's paid on a contractual basis so much a week. And it works.
He's the one that coaches him in the one with the Nigerian.
Yeah, right.
Or is she done it?
She has done a fantastic job with it. It has to, from time to time, be a burnout type position. Because you get calls, sometimes you get calls at 3 in the morning where she had one at 2 o'clock in the morning, somebody was wanting birth control.
Very important.
Yeah, right, exactly. She says, I'm sorry, you're going to have to come in the morning for that.
Not very helpful. It's not that I'm doing the doctor.
And she's got kind of situations where people have called for appointments at odd hours in the night. Sometimes it is really abused, but a lot of times it's essential. And for this many physicians and coordinating it, it's absolutely essential.
We got I guess, go around the table a minute, we're getting close to, we agreed on
Yeah.
so if we want to, you know, a Quaker knows very well what having the last few words of silence means. You might give them the last few words of silence since they are notorious for doing silent prayers. And, I think the last word is some wisdom on it, but there might be some questions, but they might want to stay on it.
I answer one quick question. That's all. Is insurance affecting you at all? I see professional insurance is less than $10,000. Is that? I mean, am I just having a wrong image of this state as compared to other states because I don't know anything about
Well,
health?
generally, North Carolina has a cheaper malpractice insurance than other
So that's
areas.
For
At
$3.
the same time, our malpractice insurance just went up about 100% in the past year, without our having any claims or any problems or anything else.
Nobody does it cut it.
well.
No, because you've got, other than, Ed will intubate a baby or something like that, and we do deliver. Yeah. And of course, Joe will put in a pacemaker.
The old one insurance.
This is malpractice combined and all.
No, they're all combined together into one physician. It's just, it was like $4,000 or $5,000 and went up to $9,800 this year. And the one that went up the most was not the physicians, but the office. See, we have insurance both on the physicians, plus you have to have one on the corporation. because the board members and I would also be named in any suit that involved the corporation. Anything else?
Slandered anybody, liable, done everything for the lawsuit.
We've only been close to it one time, and that was over one of our staff who are no longer with us, allegedly at least violating someone's confidentiality. And we handled that without the insurance company having to do anything with it. But those are important issues. And one of the things I would say most strongly is in working with your staff, and again, the people that wrote out with me, I had talked with someone when I was just getting into the community action program stuff, which was really hot, and they had a lot of personnel problems, and I started out probably spending 75% of my time on personnel problems, ended up spending about 15 or 20%. But when I started, I asked a friend of mine who had worked with Gulf Oil and worked in the government and a couple of other things, what advice he had for me in these situations. And he gave me kind of a cliche, which I think is a fair cliche for someone working with personnel, and that is you should have a fair, fun, flexible, and firm. People come to work a lot of times because they enjoy it. They may need the money, but there are other places to get the money often. But they want to have some fun. They want to enjoy the other people they're working with and so on. So in the overall balance of things, they have to have fun. It has to be enjoyable to get up in the morning and come to work. And you'll have a lot less problems if it is than if it isn't. You have to have some policies that you stand by, some things that you say are, these are definite. One of them is confidentiality. We are firm on confidentiality. If anyone violates someone's confidentiality, they almost have the burden of proof that they did not. We can't mess with it. It's too important for practice. And we terminated someone on that basis. They argued about it. They felt afterwards, after the fact, that after they reinforced that what we had said was right, but afterwards felt that we shouldn't have done that, we should have maybe done something else or whatever. But we are uncompromising on that. Our policies say we're uncompromising. Honesty. I cannot set up any kind of internal control system that is going to totally ensure that nobody can take money from this office. There is no way that I can ever do that. It is important for me to trust the staff and to trust the people that I deal with. What I can do with an internal control system is have flags come up all over when something does happen and try to call out those situations and so on. We have never had situations where I feel, since I've been here, that there's been any theft or anything. But when our data log sheets don't immediately balance, I hear about it and I follow it. And if it happens too many times, I start wondering why. I start asking questions. So I'm firm on those kinds of things. I feel very strongly that if I can't trust you, or if you're violating the patient's confidentiality, I can't deal with it. At the same time, you have to be very flexible, I think, on some things that you sometimes feel like people are maybe abusing you or anything. People might not come in to work on time all the time. Generally, we don't have a big problem with that. We have from time to time had people who were a little bit hardy. But you gotta be able to move with those sort of things. Most of the people who work here have children. They have situations come up where they don't know what's going to happen that morning. The child may be sick and all the plans that they may take care of don't work, you gotta be able to handle that. You can't get upset with it, you can't have a policy so rigid that there's no way out of it. Someone will come to me and say, I have to have off a couple of hours this afternoon to do this and that. Generally, I almost always will immediately say, okay, go ahead. Is it covered up front? Do we have a nurse covered in the back? Are we taking care of it? If we are, fine, go ahead. Maybe you can work a couple extra hours some of the day. To be honest with you, I could probably get myself into trouble a little bit with wage and hours sometimes because I am a little bit more flexible in it. And it scares me a little bit that maybe I should be a little harsher. Maybe I should make sure that everybody checks in and checks out at a certain time, whatever. We have a schedule. We say to people, this is your schedule, this is what we expect you to go by. It's 38 hours instead of 40 hours. There's a couple extra hours there in case we need to keep them a half hour over one night because the patient's having all left or whatever. At the same time, the people that I deal with don't want to punch a time clock. They don't want to come in and go out and have to risk every time they come in and go out. And so it's a matter of reasonableness. If I feel like we're getting a little bit off, one of the things I do ask is anytime someone has some time that they've worked overtime that I know about. Generally, we don't pay any overtime because we try to take care of that within that week, so it's under 40 hours. Nobody here has ever raised a problem over that. We've had a good situation about that sort of thing. At the same time, when we had one woman who was disabled for a couple of months. People picked up and took care of the time wonderfully. I didn't have to worry about the nurses, set it all up and arranged for her time to be taken care of. They knew the rules, don't work over 40 hours, and so on. In general, I think they followed us. I didn't. And that's where I could be caught on it. But I didn't go back behind them and say, are you sure you're not working 40 hours? Let me see all your hours and everything. Sometimes I think we need to take some risks. That it would be more problem to do it than not to do it. And I think one of the things that's been most pleasant for me is the relationship that we've had with the physicians and myself in the office. We have dealt with some pretty difficult issues as a group and have built a strong trust relationship where we feel like all of us want to do the best we can do, and all of us have a general orientation that is equivalent. Nobody's out to make lots and lots of money. Everybody's out to serve the patients and try to serve them well. There is a general sense of fairness to staff, a general sense of wanting to keep things running pretty smoothly and stuff like that. And it's really been a good situation. And I think, if anything, in whatever jobs you look for, look at that team that you're going to be working with. I am considered really a partner within this practice. I'm not hired by the physicians, I'm hired by the board. Joe Berry was more than actually hired me as far as that goes, but in terms of the structure of things, I'm an equal. And Joe Berry will refer to me in talking with anyone as my partner. And we do a lot of things together, and that's important. And the chemistry of the people. We've had some people who were good folks. The chemistry just didn't. They just had different goals and different aspirations in our group, and that's helpful.
We're really grateful for your several hours